Good evening, everybody. Warm regards from Rainbow Hospitals, especially from Hyderabad branch. I'm Dr. Pallavi Chalasani, and Dr. Niraj is going to deal with the topics today. We have come up with interesting topics on this pleasant platform. It's a pleasure meeting all of you on this platform in these tough times. So the two interesting topics which we are going to deal with is recurrent pregnancy loss, that's by me, and laparoscopic myomectomy and infertility. Dr. Niraj would be dealing with this. So proceeding quickly to the topics, recurrent pregnancy loss. What recurrent pregnancy loss has to deal with is, everybody knows that the loss of pregnancy at any stage to any couple would be definitely a devastating experience. It might be emotionally traumatic when people undergo abortions recurrent times. So incidence of pregnancy loss on a global context, when you have to see this, 20 to 30% of the pregnancies are lost for some reason, out of which 22% pregnancies are lost even before a pregnancy is clinically recognized, out of which 80% pregnancies are lost in first trimester. 10 to 32% Indian women have a higher miscarriages when compared to the Western population. This is like quite high, 10 to 32%. Why do we have such high incidence in India when compared to other countries is probably because of the age that people are getting married and people are trying for conception, obesity, which is becoming a troll because of our lifestyle, excessive caffeine intake, and our habits. So the definition of recurrent pregnancy loss is quite confusing because people say that, the three consecutive miscarriages before 24 weeks of gestation or 20 weeks of gestation is recurrent pregnancy loss. And few people say that 2 is enough to diagnose it as recurrent pregnancy loss. So this session is just going to be a very crisp session with evidence, just on a practical point of view. So what is a miscarriage? Miscarriage is defined as spontaneous loss of conception before a fetus reaches viability, that's 24 weeks of gestation. So there are n number of abortion types which we have looked into, like threatened miscarriages, inevitable miscarriages, and missed miscarriages. But here in this session, we are particularly going to deal with recurrent miscarriages, which on a layman's term is called as bad obstetric history, wherein people have a lot of miscarriages. So this is just a slide which shows a classification of different types of miscarriages, which I'm not really going to deal with. Which I'm going to deal with is just recurrent miscarriages. So what is recurrent miscarriage and the definition? The definition says that in case if there is a loss of more than 3 pregnancies on a consecutive basis, then we say it is a recurrent miscarriage. This is a prior definition which we used to use. So there's something called, interestingly, there's something called primary miscarriage and a secondary miscarriage. Primary is when you don't even have a full-term pregnancy prior. Secondary is when a lady had a prior full-term delivery with a live baby and then she continues to have multiple miscarriages. That's supposed to be a secondary miscarriage. So this is a question which everybody has in their mind. Should we really start investigating any couple as soon as they come with, miscarriage, a single miscarriage or a second miscarriage, or should we wait till they really have a third miscarriage? Are we doing the right thing? Probably we can start off with a second miscarriage. So clinical investigation should be started as soon as there is 2 consecutive spontaneous abortions. And in case if somebody has these 3 important lines, that is, when a fetal heartbeat is seen prior to a miscarriage, if the woman's age is more than 35 years, or if they already has taken any fertility treatments, or if they have difficulty in conceiving, don't wait for the third one to happen. I think it's better we start off our investigation and dealing with stuff as soon as there is a second loss or even a first loss. So the defining criteria has been changed by ESHRE. So now the defining criteria for recurrent miscarriage is definitely the loss of 2 or more pregnancies from the time of conception to 24 weeks. This is the standard definition which we have to follow. Pregnancy to be confirmed by either a serum beta HCG or a urinary test. So what's the incidence of recurrent miscarriage? Why are we so much worried about this recurrent miscarriage stuff? 15 to 20 pregnancies in general population are undergoing this stress, out of which in first pregnancy we are losing almost 13% of them. And after a first abortion, interestingly, the abortion rate increases up to 17%. In case if the lady has a second miscarriage, the rate increases more than 38%, which is quite devastating. And after the third abortion, it's almost 55%. So I think 38% is quite good enough to intervene. What are the causes of recurrent miscarriages? There are n number of causes. Probably we can divide them into three, which is a broad headings of maternal, fetal, and male. And there's a quite interesting topic where an unexplained factor comes into a play in recurrent miscarriages. Don't skip or miss unexplained factor when you're looking into a recurrent miscarriage people, or when you're investigating them. So in a maternal factor, what all do we have to look into is all these things. That is the age, your hormonal disorders, metabolic disorders, any infections, lifestyle, environmental factors, and chromosomal abnormalities. And on the embryonic side, we have to look into the chromosomal factors, especially because it carries almost 90% of it. Male factor is really important, which we give a lighter look on it. But make sure that you see a recurrent miscarriage couple as a couple instead of seeing them alone. Unexplained factor have to be looked into. Coming to the cytogenetics, so there are two types of cytogenetics which we have to deal with. One is if the parents have any abnormal chromosomes, so that is the paternal chromosomal rearrangements. This mainly is because of the balanced structural chromosomal abnormality or balanced translocations, which we say. But the incidence is quite high, that is almost 2 to 5%. So these people are just carriers, like the parents are just carriers, out of which so many people look phenotypically normal. So the problem with them is they completely look normal, and they think that the things with them are completely normal. But when they come with recurrent miscarriages, when you tend to do a test called karyotyping, and when you find that there is a balanced translocation in one of the couple, let it be a male or a female, then definitely we have to give a genetic counseling or send them to a geneticist, so that at least they find out what type of chromosomes are affected, would they have an impact on the future pregnancies. So these are the important things which we have to look into the carriers, because they are phenotypically normal, but they definitely have an increased risk of miscarriage. Even in case if somebody has a live birth with having a balanced translocation, they might have they might give birth to a live baby who might have multiple congenital abnormalities or a mental disability. So definitely, if you are looking into recurrent miscarriages, don't miss on doing a karyotyping for parents. So on the embryonic side, as everybody knows that the incidence is almost 30 to 57%. It's almost 90%. That's what we say to the patients when it's in the first trimester. That's before 12 weeks of gestation. Any loss, we definitely first rely on the chromosome abnormalities. That is the chromosomal rearrangements, or it might be a balanced translocation, or it might be a cross translocation as well. But in case if you miss that on a normal people, that's okay. But the main factor which you have to really look into is advancing maternal age. As you all know, the fertility rates drop almost by 50% at the age of 35, and at the age of 40 or more, it drops by 90%. So that's where the recurrent pregnancy loss also increases. More than 35 years or more than 40 years, everybody knows that aneuploidy rate almost doubles or triples. So this is where you have to pick in, seeing the chromosomal abnormalities in the miscarried babies. So what investigations would you prefer are the parental karyotyping and doing a genetic counseling in case you find a balanced translocation, just to see a familial tree wherein how much of percentage would be carried to these babies. In case if there is definitely a carrier which is going to come to the baby, and if the percentage of carrying capacity is more in these chromosomal abnormalities, probably the treatments you can opt for is doing an IVF with PGD, or directly go for a donor gamete. So karyotyping of products of conception, this is a general question which is actually devastating to say even to a patient when they have a miscarriage. If somebody has a miscarriage and you have to say that after having a miscarriage your baby has to undergo an autopsy, yeah, it's quite stressful to even utter that word to the mother who is already lost a baby for some reason. But still, I think you have to convince them to undergo this autopsy, so that at least you know what problem or what karyotype or what chromosomal abnormality that baby is carrying. It is said that the risk of miscarriage as a result of fetal aneuploidy decreases with the increasing number of pregnancy loss. That's quite interesting, and at least it's quite supporting so that you can proceed for the next pregnancy. If the karyotype of a miscarried baby is abnormal, that means this patient might have a better prognosis in next pregnancy. Genetic factors, definitely, if at all the parental side there is a chromosomal abnormality, genetic counseling is a must. You have to send them to a clinical geneticist wherein genetic counseling would be done. First of all, why genetic counseling? Why do I have to send them there? Because probably it might say the risk of this karyotyping or a chromosomal abnormalities which would go for the future pregnancies, and you can actually think of what you can actually do, whether you want to go for a PGD or whether you want to go for a donor gamete, so that you have a clarifying picture, so you can counsel the patients depending on that. Unbalanced chromosomal component. So basically this unbalanced chromosomal component, it just carries to a few parts of the familial tree. In case if it is only just 25%, that means 75% of the babies can still be normal. So you can actually say them, okay, 75% we can still try normally. And familial chromosomal problems definitely have to be looked into, because we do not want to give a baby also a chromosomal problem which is going to suffer same like their parents, like how they are suffering now. So what are the treatments? Definitely it is prenatal diagnostic test has to be done. In case if something is going wrong, then you can opt for gamete donation, or you can directly say them adoption. I really want to make it a point saying that in case of an unexplained recurrent miscarriages, pre-implantation genetic screening or doing an IVF is not going to treat the cause, because it's unexplained. It might not improve the live birth rates. So the things which we have told in last 3 slides have to be done only for the carriers who have a balanced translocation. So polycystic ovaries, I think polycystic ovaries is quite rampant nowadays. Half of the OPD is filled in fertility clinics with the PCOS candidates. So why is PCOS very important in having a role of RPL is because they have increased in insulin resistance, hyperinsulinemia, and hyperandrogenism. Because of all these 3 factors which the PCOS carries, it has a higher impact on recurrent pregnancy loss. So what's the treatment? Would something help decreasing this? They say that suppression of high luteinizing hormones, either by giving OC pills for either 2-3 months, or doing a LEOS in case you have a resistant PCOS case where whatever you do, the LH levels, if they are not coming down, that would be the last option of doing LEOS. It might help, it might not help. There is no standard article or RCTs which actually says that okay, this is going to definitely benefit RPLs. So you can just try it out in your clinic. If something is working out, well and good. Metformin, again, it's controversial to whether to give it after a lady is pregnant in case of PCOS, but in Rainbow we generally follow that metformin is being given at least till 12 weeks of pregnancy, and then probably we can taper it and stop it. We have seen that multiple miscarriages are not happening when we try giving metformin. Unexplained infertility, definitely do not take it light, because it is almost 50 to 75% of couples who are struggling with RPLs are because of unexplained category. And psychological support is the main thing in unexplained category, wherein there is no treatment, as all of us know, but psychological support and tender loving care would definitely bring out 50 to 60% of people out of this. So rest of the topics, very important. How do we investigate RPLs? There are a lot of etiologies which we have to deal with. One of them, very important topic, is anatomical structures. That means when you have a uterine abnormality like either polyp or fibroid or septum, whether it might be subseptate uterus or a complete septum. So these are the 3 important abnormalities wherein you keep seeing recurrent pregnancy loss. So Dr. Niraj would be dealing in depth with fibroid, and as everybody knows that the investigation of choice in OPD would definitely be a sonohystogram. So sonohystogram as a routine we can do for a patient whom you're suspecting an anatomical abnormality in the uterus. So it's a very simple procedure wherein we just push some 20 ml of normal saline into the cavity under transvaginal ultrasound to see if there is any of these uterine abnormalities, including bicornuate, didelphys, and you can also see if there is any subseptate uterus or polyp. So these are the things which you can easily find out with a very simple trick called sono. In case you find something abnormal, then probably you can proceed doing a hysteroscopy for a diagnosis. And in case you have a doubt in between bicornate uterus and diadelphys, you can proceed doing an MRI. And endocrines, definitely don't take a lighter note on the blood test. Thyroid, prolactin, and diabetes is definitely going to take a major role on recurrent pregnancy loss. And interestingly, nowadays, the premature ovarian aging, which is also having a lot of impact, has to be ruled out before you see an RPL case. So these are the 4 investigations which you definitely have to see, other than your hemoglobin levels, which also matters a lot. Infections, definitely there is a lot of infections in India, especially bacterial vaginosis and candidiasis, which is in high rampant in Indian scenario. And genital tuberculosis, never give a lighter note, because as everybody knows that tuberculosis is on high incidence in Indian population. Immunological tests which you have to really run them through is, in case if they have 2 abortions, it's good enough to do a lupus anticoagulant, anticardiolipin antibodies, protein C, protein S, and antithrombin 3 and 5 factor, and Leiden factors. All these factors have to be done so that at least you can put them on a prophylactic ecosprin to safeguard them from immunological and thrombophilic effects. Chromosomes, I think we have dealt with in detail. By doing a karyotyping also, you can find out these things. And environmental, never take a lighter note on environmental things like alcohol, smoking, and occupation. Make sure that you emphasize on the occupation also, because the stress factor is going to take a larger impact. So probably tender loving care, again, the psychological counseling is also very, very important in RPLs. So when you come to the psychological part, anger, depression, anxiety, everything comes into play for a patient who is already having a lot of stress because of the RPLs. And in case if this is a scenario in COVID times, they would definitely have a more impact. So make sure that you spend at least 2 to 3 minutes dealing with the stuff. TORCH, again, it's a big question whether this panel of tests of TORCH should be done or not. I think bacterial vaginosis and candidiasis and tuberculosis, if you have ruled out these 3 things in recurrent miscarriages, and I don't think so TORCH should be done as a routine panel. I think it's because Cochrane review has categorically proven in multiple meta-analysis that TORCH group of infections are not responsible for recurrent miscarriages. Again, I repeat, TORCH is not responsible for recurrent spontaneous miscarriages. So I think we have to say a big goodbye to all this panel of tests in case of when you deal with a patient of RPL. So how do we really go about it? So detailed history from both the partners is very, very important. If you have a previous miscarriage, take a detailed history of the previous miscarriage. Familial history is definitely very important. Any modifiable lifestyle changes, definitely deal with them. BMI has a major role to deal with. If somebody has a lot of BMI of more than 30, either if it is a male or female, please deal with it. And occupation definitely has to be looked into. And the treatment options for the list which I have mentioned prior, any anatomical structural abnormalities, I think the answer is laparoscopic or hysteroscopic removal. In case if it's a polyp, probably you can do a hysteroscopic removal. Submucous fibroid can be removed. And in case if there is TB and then there is additions, lot of additions, adhesiolysis can be done, and then you can probably do an IVF case on them and pick up the eggs and then freeze them and then recreate your endometrium and probably go ahead with a transfer that after a TB test is negative. So this type of treatment for especially for tuberculosis would definitely help. And I would also insist doing a trial endometrial preparation in cases you suspect tuberculosis, because once you do a trial endometrium, you're very confident whether the basal layer of the endometrium is scraped off with TB or not, or whether you can actually predict your success rate with IVF. So that's how we do it in Rainbow. Endocrine factors, thyroid replacement therapy is definitely a must. So thyroid cutoff values, it's very different in different labs, but we would say that in fertility, if somebody is trying for fertility or if the person has a lot of RPLs, the TSH value should be, the cutoff value should be less than 2.5. In the first trimester, it is less than 2.5. In the second trimester, it is 0.2 to 2.5 or 3. And in the third trimester, it is 0.3 to 3. Probably these are the values which we have to follow, because previously we used to follow less than 5 is supposed to be normal, but that is not anymore. In case if somebody has a normal value of 2.5 and still they have a recurrent pregnancy loss, if you still have a doubt, please go ahead and do an anti-thyroid antibodies. In case you find the anti-thyroid antibodies and still find your thyroid levels being normal, proceed and treat them as hypothyroid patients, and they really do miracles with RPL cases. And in case prolactin, don't take it light on a lighter note, because prolactin, there is a lot of debate nowadays, say asking whether prolactin has to be done on a regular basis or not. I think we have to do prolactin on a regular basis, because hyperprolactinemias not only cause RPLs but also cause a lot of infertility issues. Recently we had a case in Rainbow wherein we did a prolactin and then it was 400 plus, and we sent her for an MRI and then we found a large macroadenoma. It's like life saving for the patient also. The patient would have gone for a lot of other abnormalities like headache, optic nerve compression, and diplopia and things like that. So doing a prolactin doesn't harm the patient. Probably it might help the patient some other way, like how it did in this case. So when you have higher prolactins, you can give them cavagolin, that is almost like 0.25 mg. BD dose for 5 days would do. Make sure that if their prolactin levels are very high, definitely an MRI and thyroid management should be done. And diabetes, definitely the test of choice would be OGTT. That is, do a fasting test, and 2 hours later, after giving a 75 grams of glucose, do a 2 hour later test after giving a 75 grams of glucose shot. That would be the best test which picks up diabetes. So metformin would be definitely a drug of choice in case the sugar levels are very high. No wrong in taking endocrinologist opinion and going ahead with insulin therapies. And immunological or thrombophilic, any problems are there, you can always rely on low dose aspirin and heparin. A lot of infections can be treated with antibiotics and antifungals and AKT drugs if in case the patient has endometrial TB, and if there is a chromosomal problems, the counseling and reassurance is the only option which we have, or you can opt for IVF and PGD. In case if you have environmental factors or lifestyle changes, you have to give a great impact of saying that you have to deal with stop smoking and stop alcohol and have a good balanced diet and do a regular exercise. And endometrial receptivity, the progesterones and adjuvants, I'll just deal with it in my next slides. A major thing which everybody has when you see a recurrent pregnancy loss patient is a luteal phase defect. What the luteal phase defect is proposed since almost 1949. It's that old luteal phase defect is, but still, even if it's like said from 1949, it doesn't have a proper definition, nor it is like very controversial. The definitions are very controversial. We really don't know what mechanism is causing luteal phase defect, other than we think that the progesterone levels are not properly secreted from the uh, corpus luteum. That's the reason why we have luteal phase defect. So these are the major reasons, and there is no proper diagnostic test which is reliable, or there is no validity for any of the tests to actually prove that this patient has luteal phase defect, except for the treatment remains the same. It is a progesterone supplementations. So the definition, as I said, it is just a inadequate production of progesterone from the corpus luteum to grow a proper endometrium, which is very receptive for the baby to be picked up. So there is a lot of confusion about this luteal phase defect. So the only answer of luteal phase defect is just giving the progesterones. So how do we choose progesterones? Which progesterone is right? So we should actually take a criteria for doctors and also for patients. That's very important. So for doctors, definitely it should be evidence-based. The efficacy should be good with less side effects and the good results. On the patient side, it should be very convenient and the compliance should be good enough, and it should be of taking very easily, and the results should be good enough, and the cost and the availability should be easier. So this is a timeline of progesterones. I think everybody knows this. I don't want to run into that slide. So there are n number of progesterones. It's very confusing to know which type of progesterone which actually helps stopping the luteal phase defect or RPLs. So the modes of progesterones which we have now in the market is injectable, vaginal, and oral. All three of them, when it comes to endometrial receptivity, all three of them is the same. It gives the same impact. but the side effects probably are different. That injectables have a lot of pain, and somebody has to give the injection, and we need a second person to give an injection. There might be itching or injection site abscess and all that. Vaginal progesterones are definitely very the compliance is the matter here. Probably the patients are not very comfortable using the vaginal progesterones. Oral progesterones are definitely easier, the most easiest route and most acceptable route of administration. So in oral progesterones, we have two types of progesterones. One is micronized progesterones and one is dydrogesterone. Again, we have a lot of confusion which progesterone to deal with. So oral dydrogesterone is the majorly used oral progesterone, and the micronized progesterone, here we generally use it as a vaginal progesterone. It has a great impact on the vagina. And so oral dydrogesterone is what we generally, a lot of population in us use. So because of greater bioavailability, it is effective at a lower dose. It improves the endometrial receptivity and also the pregnancy outcomes with a greater impact and very minor side effects. This is about the progesterones. So we can pick any progesterone if you want injectable progesterone in case of IVF, and vaginal progesterone if the patient is good enough and with the compliance, you can give them vaginal progesterone. If the patient insists, no, I don't want both of them, you can always go for oral progesterones. I think all three of them does a very good job. Coming to the other adjuvants, there are a lot of adjuvants which can improve your recurrent pregnancy loss or continue the next pregnancy. Prednisolone, which we have seen, has a lot of beneficial effect on autoimmune inflammatory, and even in case of infertility, when we start off in follicular phase, that is from day 2 of the cycle till day 20, that's what I give them, and slowly taper and stop off. I start off with dexamethasone, which is 0.25 mg OD per day. That's what we recommend. We have seen quite a number of cases working out well, but there are actually no studies or RCTs or meta-analysis which actually proves this. So again, I leave it to every individual how they practice. And intravenous immunoglobulins, we are not really into this, but it's the evidence says that it is not statistically significant in improving, live birth rate. There's only one study, that is also a Chinese study, which says that the live birth rate significantly is improved with the treatment when it is started prior to conception. This is what that Chinese study says, but it is not recommended unless further studies are coming up. Intralipids are definitely the mechanism of action of intralipids is killing the natural killer cells, and the cytotoxicity is reduced, and then it can improve. But this intralipids, actually, when you ask us our personal experience, we are using intralipids when we are doing FET cycles in recurrent pregnancy loss patients or recurrent implantation failure patients. And we have actually done a pilot study wherein we have seen there are quite good results with intralipids. The way we do is one day prior to our embryo transfer, we give intralipids as an IV infusion. It comes as 20% intralipid in 100 ml, wherein we mix with 400 ml of normal saline, and it runs over 4 to 6 hours. This is how we give. In case the patient gets pregnant, then immediately a day after her pregnancy test, that's a beta HCG test, which we do after an FET after 14 days. So immediately one day after that, we give another dose of infusion, and 1 month later after the second dose. This is what we are practicing here, and we have seen quite good results in our in RPL patients. But definitely, when you ask me where is the evidence, there are no much RCTs. Probably we're waiting to see RCTs. IVF and ICSI, in case of chromosomal abnormalities, if you find a lot of chromosomal rearrangements, you can opt for PGD and PGS, or you can also opt for gamete change or donor oocyte program or a donor sperm program. This is all about the first trimester losses. Recurrent pregnancy loss is not only about the first trimester, but also remember it is also about the second trimester. So definitely cervical weakness is one of the major factor. So serial cervical ultrasounds to see for cervical funneling and cervical length, anything less than 3.5 centimeters is to be looked into. And always in case of RPLs, always plan for singleton pregnancy implantation. So when you do an FET or if you do a fresh transfer, make sure that you implant only one embryo instead of going for 3 embryos as a routine norm. Cervical encerclage as a prophylactic way can be also done. Dr. Niraj, who is in Rainbow, Hyderabad, is very good in doing cervical encerclages and abdominal encerclages, and we have n number of cases wherein the patients have gone for full-term deliveries and delivered a happy baby. So thanks to all Dr. Niraj. no evidence that this procedure has increased the perinatal survival. That's what the evidence says. But in our practice, I think we have done good cases of cervical encephalitis and sent home babies happily. So I have dealt with the maternal and fetal part of it, and nonetheless, please make sure you also see the male factor, because lifestyle of male, age of the male is also very important, and the BMI, their occupation, metabolic disorders, and family history. All these things have a greater impact on the sperm quality. Whenever you see a sperm analysis report, we just see only the concentration, but you have to always concentrate looking into the motility and the morphology, and also look into the pus cells. If there is a pus cells, that means if the semen is infected, probably a little antibiotic would stop getting recurrent pregnancy losses. So please look into all those 4 factors. In case you have a recurrent miscarriage, there is no wrong in doing SCSA, which is called a sperm chromatin study, wherein we see for a DNA fragmentation. So as everybody knows, there's something called as DFI. So any DFI more than 30 says that there's a lot of fragmentation in sperm chromosomes, and so we have to get that below 30. Or 15 to 20 is a good DFI. That's what we say. How do we get that down? Is by the antioxidants. Probably you can put the male on a lot of antioxidants, stress on lifestyle modifications, ask them to exercise, ask them to eat a balanced diet, and make sure that they don't have alcohol on a regular basis or smoking on a regular basis. So these are the important things which can actually affect the sperm and cause a DNA fragmentation, which is actually leading to recurrent pregnancy loss. So counseling and lifestyle modifications would definitely help with the male factor. And in case if you want to proceed with treatments in such scenarios, IUI, IVF, ICSI, sperm retrieval, and minor surgeries for sperm retrieval can also be done. So I think we have dealt with all 3 major factors which actually causes recurrent pregnancy loss. So never quit. So while there is life, I think there is always a hope to see a little one. So the next topic, the questions would be dealt in the later session after Dr. Niraj deals with the next topic. So probably you can listen to Dr. Niraj talking on laparoscopic myomectomy and infertility. Thank you so much.
Okay, so I'll start now. Well, thank you, Pallavi. That was a very nice, elaborate talk. I must say, you have touched on every single possible cause which can lead to these recurrent miscarriages. Thank you. Now, I'm going to start with my talk on laparoscopic myomectomy and infertility. For those one sec, why is this not working? Yeah. So now, laparoscopy is here to stay. There have been initial criticism about laparoscopic surgery, especially when you deal with larger fibroids. But now I think we've done very large fibroids laparoscopically, and therefore we can very confidently say that there definitely is a role for laparoscopic myomectomy, and it is here to stay. Now, it, I believe, is the gold standard for dealing with any fibroids. When I say any fibroids, yes, I mean any fibroid and including multiple fibroids. But I'll talk about the number of fibroids later, where we can probably say laparoscopic myomectomy is not a great idea. And then there are, of course, proven benefits of laparoscopic surgery, which I don't want to go into now. When you talk of a myomectomy, these are the various routes you can do by a myomectomy by. Hysteroscopy, obviously, for cavity fibroids. And I've just kept here hysterectomy because this was from my another talk somewhere in Chennai. This slide I've just borrowed from there. So hysterectomy, forget about it. For this particular topic, that is not even an option for us. But myomectomy generally will be done in those who have symptomatic fibroids and those who have failed to respond to medical treatment. Now, what are the factors that determine whether you go for myomectomy? I mean, it is an answer which I think is a definitive answer when it comes to doing or dealing with infertile couple or infertile lady. For submucous myomas, hysteroscopic resection is the best one. Anemia obviously should be corrected because most women who have submucosal myoma will have had menorrhagia as well, so they're likely to have anemia. You must correct that before embarking on the surgery. And then there is a controversial role about selective progesterone receptors, modulators, as well as GnRH analogs. I'm not going to go into that because this is not talk about laparoscopic myomectomy per se. Now, just briefly touching upon the steps of laparoscopic myomectomy, they remain the same as for open. You enucleate the myoma, then you suture the myoma bed. The only difference in laparoscopic surgery is, of course, you needing the skills to do laparoscopic suturing, as well as retrieving the fibroid. Now, after having gone through a controversial phase about use of morcellators, now they're back in business. We're doing morcellation of fibroids, and that obviously is a different step, which will not be an issue when you talk about laparotomy. Port placement, again, I'll not go into details here in this particular talk, but now there is still a school of thought which says that you should give gonadotropin releasing hormone analogs before embarking on the surgery so that you have less blood loss. But to be honest, we've done now thousands of laparoscopic myomectomies, and never did we have bleeding as an issue, or I never regretted that I should have given GnRH analog for this particular patient. Never happened. So essentially, I'm not a great proponent of this. I would not suggest it should be given for one reason, because also that it tends to lose planes. You don't get as much clearer planes to dissect the myoma, to enucleate the myoma, as you would when you don't give GnRH analogs. Ulipristal, again, it's a new kid on the block. There's still people trying to evaluate its role, so I won't really advise that. As far as vasopressin is concerned, yes, vasopressin is one of the things we need for every myomectomy. Now, this is a large myoma, which you can just see. This is only demonstrating the vasopressin. You can see how the vasopressin will actually change the color of the fibroids. It's a huge vascular fibroids with tortuous vessels. You can see how it goes, and they all turn white the moment you give vasopressin. You can see how beautifully it creates. Now, the key is when you're doing myomectomy, when you have this avascular area, you have to finish off your myomectomy, and you must have started suturing by the time the effect of vasopressin goes off, because then the myoma bed starts bleeding, and that's where your surgery can get a bit of I won't say annoying, but yes, it can start getting annoying, because if it starts bleeding, then you don't really like the whole surgery. You don't enjoy the surgery. Suturing, I mean, it can be done with absorbable sutures. That's what we use nowadays. Many people do use barb sutures, self-retaining sutures, which is also good. I have nothing against it. And barb sutures have been shown in studies to reduce the operating time. Again, this would apply more on the surgeon and the surgical skills about laparoscopic suturing, and it does improve hemostasis as well. Now, suturing, we do close it in golf ball kind of technique, wherein the edges are not exposed. We try not to expose the edges, but having said that, even if the edges are exposed a bit, it doesn't matter, because we do use almost for every woman who has fibroid adhesion barrier in the form of interseed, which kind of takes care of any adhesions if at all happen. The idea behind suturing is to preserve the endometrial cavity. This is more so when you talk about myomectomy in an infertile patient, and also you should have very good hemostasis, and you should reduce the risk of hematoma. The importance of that I'll tell later in my slides. Retrieving, again, there are some people, some surgeons who may say that they don't want to use a morcellator, or it may not be available, or because they believe in the controversy which has happened a few years back, which was I think 2013-14, and they convert to mini laparotomy. But I think the fun of the laparoscopic surgery is gone the moment you do mini laparotomy and remove the fibroid that way. If it's small enough, or if it's large enough, whatever you look at it, you can remove it through posterior fornix, which is also a good natural route, and it can heal very nicely. And a morcellator is something which we use for most of the fibroids. Now, a morcellator is again an equipment which I'm sure those of you who are using will know that it is one of the most what shall I say, dangerous instrument, if at all there is one. But again, it is not dangerous if you use it safely. But there have been quite scary reports in literature about misuse of a morcellator, which has led to very bad morbidity and even mortality. So you should use it with absolute caution. That is what you must always remember. Now, coming to the topic, this was just brief view about fibroids and laparoscopy. Now coming to the core topic of fibroids and infertility. It is not uncommon. We all know fibroids are very common. And in infertility clinic, you might get 1 out of 10 infertile patient who is having fibroid. As a sole factor, assuming that everything else is normal, it can be seen in up to 1 to 2.5%. Again, these are Western literatures. They may or may not apply to our population, but by and large, I believe these figures will exist even in our population. Most of the evidence, again, as I said, is also from Western literature, as well as they are non-randomized. Now, fibroids do not mean there is always a causative link with infertility. This statement is 100% true, because there are many women who we see are pregnant and have fibroids. So we see so many women who are pregnant with fibroids. So having a fibroid does not automatically mean that one is going to have infertility. But in those who have infertility, it may be secondary to deformation of the uterine contour, which I'll show you in a few slides from now. Alterations in uterine contractility may interfere with sperm and ovum transport. And endometrium can also be abnormal or inflamed overlying the fibroid, which may impact successful implantation. This can happen in natural pregnancy, and it can also happen in artificial reproductive technique methods. And there's significant deficiency of cytokines that are necessary for early pregnancy implantation. These are all proven. These are not only hypotheses, but these are something which have been shown in several studies. Now, when you look at effect on implantation of in IVF cycles, intramural fibroids significantly reduce implantation rates, and the fibroids more than 3 centimeters have recurrent implantation failure or lead to early miscarriages. 3 factors determine the outcome of fibroids and fertility. 1, number of fibroids. 2, location. And 3, size. Everything about fibroid, I believe, revolves around these 3 things, and this eventually will lead to your fertility outcome as well. So when you talk of number of fibroids, now it's not always easy to assess the number of fibroids on ultrasound scan preoperatively, and there are very few who would actually give exact number and location of fibroids. We have Dr. Pallavi here who does give us good number, Dr. Preeti, and we have other colleagues as well who give very good location and mapping of fibroids, which does help us. I mean, MRI, I believe you may do it, may not do it, depending upon how you feel about the surgery or the proposed surgery at the end of your history taking and clinical examination and ultrasound scan. So MRI, I wouldn't say is a must, but yes, it is a tool available to us. If you feel more comfortable doing it, please do it. Now, does size matter? Yes, size does matter, because it is an important prognostic factor, and there have been studies which have shown that 5 centimeter fibroids is the size limit that appears to justify myomectomy. So anything which is more than 5 centimeters, the advice is remove it. And pregnancy rates range between 44 to 62% following myomectomy. So you can see that that's a significant number of women who will get pregnant after myomectomy in those who have had myomas removed more than 5 centimeters. And time to conception, you can see that almost 80%. This is what I tell my patients when I do surgery, that this applies mostly to even polycystic ovaries, this applies to endometriosis, this applies to fibroids, that the outcome of the surgery as far as fertility is concerned, it's maximum during the first year following surgery. Now, these are the 2 different standard universally followed classification of fibroids. I'm not going to read them out, but I'm sure most of you are aware of it. Almost all of you are aware of it. Now, submucous fibroids, when you look at it, it does cause distortion and enlargement of endometrial cavity. These women typically will have menorrhagia apart from infertility. So they would in fact present, most of them would present with a menorrhagia and anemia symptoms and also infertility. It does affect implantation because of the mechanical distortion of the uterine cavity. And there is focal endometrial vascular disturbance, inflammation, and secretion of vasoactive substance as well. Now, dysfunctional uterine contractility and interfere with sperm ovum transport. This is also a hypothesis which I'm sure no one will have any problem agreeing with. And it does, again, location. I don't have the video in this particular presentation, but I have very nice video where I could show that the 2 little polyps or fibroids which are nicely obstructing the ostia on both the sides. We removed it, and within 2 months the woman got pregnant after 5 years of infertility. So the submucous fibroids, as you can see, they really distort the cavity. This is hysteroscopic view. Now, again, if we believe ultrasound scan, the report which we had got from outside, this was a patient referred from outside Hyderabad. We were told that she has only 1 fibroid in the uterine cavity based on the scan. So in any case, I did not do an MRI. To be honest, it would not have made any difference even if I had done MRI, because the surgery would still have remained the same, the outcome would still have been the same. You can see even here one can argue that the fibroid is obstructing the the tubal ostia on that side. And you can't remove those kind of fibroids by hysteroscopy. I do hysteroscopic resection of fibroids, but those are the fibroids which I will not think of, because it will not work out as nicely as it would when you do laparoscopic myomectomy for these, for two reasons. One, they were large, and second, they were multiple. So hysteroscopy will obscure your view of doing a successful myomectomy, and it will be time consuming as well, and I don't think the results will be as great. Now the other side, I'm showing you how the feeding vessels can be nicely tackled without using energy source. I'm not using energy source here. You can use, but by not using the energy source there, what I have done is I have left the vascular supply in it. I kept it nice and vascular, so the healing is better. The more you use cautery, the more you use energy source in the uterine musculature, the more likely that you might have hematoma formation or a weak scar, which might give you problem when the woman gets pregnant. So even while there was a solitary fibroid which was removed on the right side, you can see that I'm still peeling off fibroids from the other side, and these are coming out. They've been small fibroids as well. Now in these situations, it's always handy to do a hysteroscopy prior to doing laparoscopic myomectomy, because I exactly knew how many fibroids I had in the uterine cavity, and unless I remove all of them, I know that the surgery is not complete. So you remove all the fibroids, and then close the uterus as you've seen here by golf ball technique, and then keep a interseed on top of it to reduce the adhesions in future. Now that was about submucous fibroids and how submucous fibroids can impact infertility. Fertility. Now, when you look at anatomical distortion, this lady would have never got pregnant. I mean, it's because her cervix was completely pulled up. On vaginal examination, you could not even feel the cervix. So there's no way a natural conception can happen in her. And more importantly, even when you look at the anatomy or the location of the fibroid, it would have been difficult to perform IVF. So we did this, and these all slides which I'm showing you, these are all surgeries which I'm showing you. All of them, but for one which I'll tell you, all of them got pregnant at some point in time following the surgery within the year. So that was a cervical fibroid. Then there are these broad ligament fibroids. You can see here, this is a large broad ligament fibroid which is completely squashing the uterus to the right pelvic side wall. So it's distorted anatomy. This lady, you cannot expect to get pregnant. Even if she gets pregnant, I don't know how successful the pregnancy will be in terms of outcome of pregnancy. You can see it's vascular. The more important thing, it is pressing on the ureter. You can see the ureter right there. So the peristalsis is seen, and that was completely distorting the anatomy. So you remove these fibroids, and these women will get pregnant. So yeah, sorry. When you talk of technique now, Pallavi, are you able to hear me? Hello?
Yes, sir, I can hear you. Yeah.
Sorry. Yeah. So now this is a very nice study which was conducted by who happens to be one of my very good friend, Gernot Hudelis from Austria. They did a very nice study, and this was published in I think Human Reproduction Journal a few years back. And what they have shown is there is a clear hyperechogenic pseudocapsule around the fibroid. Now, many people, including very good endoscopic surgeons in India who I have spoken to, don't believe that there is a hyperechogenic pseudocapsule or a capsule. But there is. This study has proven that there is that pseudocapsule, which carries nerves and vessels along with it. And if you preserve that, and on the scan it will appear as ring of fire in the pseudocapsule, as you can see here. If you are able to preserve this, and if you do intracapsular myomectomy, then it's more likely that the healing will be very nice, and that will also give you more success rate when you talk about pregnancy following the surgery. Now, it helps in healing process as well as good fertility rate, and it needs a bit of skill and acceptance that there is that capsule which you need to preserve. If you just go in and you want to do a myomectomy, don't care about that, then probably it may not be as good an outcome, and that is what that study has exactly shown. Now, the very large fibroids, again, they will cause difficulty in conception. They interfere with conception and reduce effectiveness of assisted reproduction cycles as well. Pedunculated myomata do not have detrimental effect on fertility. There are many pedunculated, but the pedunculated ones may cause problem in pregnancy because they might actually tort. And pure intramural fibroids had decreased rates of implantation and ongoing pregnancy and live birth. And those intramural fibroids which you have removed, if you have removed, then they increase the success of the pregnancy. Now, this is the lady who hasn't yet got pregnant. She's not. The reason is she has not tried for pregnancy yet. This is the surgery which I did in April or May 2019, which is just over a year. And she is not planning pregnancy. I mean, I saw her a couple of months back. We had some video conference with her, and she did not say that she's planning pregnancy, but she's fine. Now you can see that this is a 32-week size fibroid, and it's almost touching the xipisternum, and the umbilicus is way down. So these are the large fibroids. This lady is not going to get pregnant. There's no way she'll get pregnant, and even if she gets, there's no way the pregnancy is going to go to term. Forget about term. She may not even reach second trimester of pregnancy. So these are the fibroids which can be removed laparoscopically, and therefore initially when I said that any size myoma can be removed, this is where I come from. Now these are the vascular fibroid. You can see it's massively vascular, right? All over you'll see only huge pipeline like blood vessels, and the liver, you can see the liver edge is 2 to 3 centimeters away from the upper edge of the fibroid. You move the camera a bit and you can see on this side there is you move this omentum and the spleen was there. So essentially you have very little room to maneuver, because on one side you have the liver and the spleen. On the spleen is not a major problem, but liver may impact your maneuvering ability of the fibroid. And the round ligament, no surprise, is on a stretch. And these are the adnexal vessels. You can see the adnexal vessels are so engorged, and no amount of vasopressin is going to be enough for this. But therefore you have to tactically decide where you're going to put the vasopressin for you to, and on top of that she had 2 posterior fibroids. So that large one, when we removed, we could see these 2 posterior wall fibroids along the body. It was not a more like broad ligament, but then after having removed that giant fibroid, removing these 2 10 by 10 centimeter, 8 by 8 centimeter fibroid was not really a big problem. So so at the end, so that was the top fibroid which we removed, and these are the 2 fibroids which came out from the posterior wall of the uterus. These fortunately, this myoma posteriorly was not in the broad ligament area. But having said that, it was, even if it was, it wouldn't have been much of a problem for us to suture. You can see that that is how we intend to suture, and that is how it was in the end. This surgery, it took almost 75 to 90 minutes, I must say, to morcellate all those 3 massive fibroids. But at the end of the surgery, and today we are very happy we did it laparoscopically, because she certainly saved off a big midline scar extending from symphysis pubis to xipisternum. This wouldn't have been possible through a phalanxil, because you can't even reach the fundus of the uterus. So there's no way she could have, and those were the scars which she had when she came for follow-up. So, and this was the video which actually I presented in European Society of Gynae Endoscopy last year, and it was accepted for video presentation. So what does the evidence say when we look at all these things? There are several advantages, and there are the issues about feasibility, indications, and risks. Universally accepted indications when you talk of infertility and lap myomectomy are submucous fibroids, the ones which I showed you earlier, intramural fibroids also, which I showed you, and multiple fibroids, which also you have seen. So those are the universally accepted indications. Feasibility, when I say, I mean location and size are the major determinants. Maximum size, some people say 8 to 10 centimeters, but clearly I don't believe that 8 to 10 centimeters should be your upper limit, because in that last video which you saw, there were 2 posterior wall fibroids each measuring 8 and 10 centimeters. So leave alone the larger one, which was almost 18, 20 centimeters. So, and the total number should not exceed 4, again, is what the Western literature would say, but I'm sure the endoscopic surgeons in India would not agree with it, because there are many surgeons, including myself, who have removed far more than 4 fibroids. What one logic which I accept, this was from the Human Reproduction Journal, was it is prudent not to perform laparoscopic myomectomy with more than 5 to 7 large myomas, because it is time consuming and the surgeon can miss smaller fibroids. I entirely agree with this, and unless you have the skill levels to do that kind of long surgeries and give good outcome, I would rather not encourage doing those kind of surgeries, because it is time consuming, it does need a lot of patience, and your skills in hour 1 may be different than your skills in hour 5. So you're not going to remain the same person as you started the surgery as you are when you're. But there are surgeons who have that confidence that you'll remain the same. Please go ahead and do it. That's what we do, because we know that once we start the surgery, we'll finish off. But again, having said that, there may be occasions where we may give up and convert. I mean, hasn't happened yet, but I'm sure that may happen at some point. And there were 20 studies which looked typically at impact of fibroids and infertility in two aspects: embryo implantation and outcome of ICSI and IVF cycles. And those are the references there. Now, submucosal, intramural, and subserous fibroids, it is now proven that they interfere with fertility in decreasing order of importance, meaning submucosal is the most is the fibroid which will make most impact on infertility, as opposed to the subserous ones, which is understandable. In this, they have not included the pedunculated fibroids, which have the least effect. Then implantation failure, yes, when the diameter of fibroid is more than 4 centimeters, it does affect the implantation in IVF and ICSI cycles. Myomectomy has been shown to improve conception rates anywhere between 30 to 80%. So 80% is massive. So essentially talking about there's a chance of 8 women getting pregnant when you do 10 myomectomies is what it is saying. I mean, at least 3 is what really you should assume. And there have been many other studies also. One of this, I think I must have, yeah, I have got this reference also here, which have shown that 235 women who underwent subserous and intramural laparoscopic myomectomy did get pregnant, and 74% of them got pregnant, which is massive number. And therefore, laparoscopic intramural and subserous intracapsular myomectomy does provide excellent surgical and pregnancy outcomes. And when patient selection is appropriate and there is no other cause for infertility, and intracapsular myomectomy is performed. These are the 3 essential things when you talk of impact or outcome of laparoscopic myomectomy on infertility. Laparotomy, I won't even debate. I don't think, I mean, please feel free to ask any questions if you have at the end, but I don't feel that laparotomy has any role for myomectomy these days. When it comes to smaller fibroids, or even the ones which is 7 to 8, 6 to 8 centimeters fibroids. But having said that, if one doesn't feel comfortable, if one doesn't have the right equipment, if one doesn't feel that they're in the right setup, please do laparotomy and remove it. There's no harm doing it. I'm only talking in a theoretical context that as far as infertility is concerned, the outcomes will be superior with laparoscopy compared to laparotomy. That is what I mean when I meant laparotomy has no role. It is purely in the context of outcomes of infertility compared to laparotomy. The 2 critical factors, there should be absence. Now, this is assumed that in women who's under 40 years age or under 30 years age and who has only one fibroid will have far better outcome than someone who's over 40 years age and has other causal factors as well, including maybe male factor. So the overall chance of conception will depend upon these kind of factors as well. Now, there are people who ask about the route of delivery after doing laparoscopic myomectomy or a myomectomy by open method. Vaginal delivery is generally safe following laparoscopic myomectomy. And in this study, again, which was from Villach in Austria, they had shown that 67% of women did achieve vaginal delivery following laparoscopic myomectomy. Now, where does the risk of uterine rupture increase following myomectomy? There is no consensus on it. But what have been noted is those who have myometrial defects on the following follow-up scans, if they do, or someone had a hematoma formation after the surgery, excessive use of thermal energy. That's where I meant about my earlier video, which I showed where I was not using a lot of energy source, and high wattage electrocoagulation. When you use these kind of things, when these kind of things happen, then it's more likely that the uterus may rupture during a pregnancy. As a matter of practice, I do keep adhesion barrier at the end of laparoscopic myomectomy and endometriosis surgery, even after TLH over the vault, to avoid adhesion formation. Miscarriage rate of pregnancy wastage significantly decreases after surgery. This is what studies have proven, and those are the references again there. When you go back to my first or second slide, when I said miscarriage rate increases because of inadequate implantation or reduced cytokine storm in that area, then this is where that particular theory is proven. And almost 2,000 women who underwent laparoscopic myomectomy, they looked at the spontaneous abortion rate, and that had come down significantly from 41% before surgery to 19%, which is a significant drop, more than 50% drop in abortion rate after myomectomy. So in infertile women, appropriate evaluation and classification of fibroids should be done. You obviously should rule out other factors, which causal factors, which may be incidental to the woman or to the male partner. Intracapsular, subserous, and intramural myomectomy, saving the pseudocapsule. That is where I said about the pseudocapsule, which has the neurovascular bundle in it, and that will definitely help you get the nice strength to the myometrial scar, as well as the integrity of the scar. And as far as your risk of rupture during pregnancy is concerned, it's reduced if you do intracapsular myomectomy. And effect of fibroids on reproductive function can vary depending upon location, size, and number of fibroids, which again is what I have shown you in the earlier videos. Submucous fibroids should be treated hysteroscopically if you think you can, and if they are less than 3 centimeters, maybe again every individual surgeon will have his own choice, his or her own choice. And women with submucosal fibroids should undergo myomectomy prior to undergoing assisted reproductive techniques, regardless of the size, because that might interfere with the success of infertility of fertility treatment. A myomectomy should be performed in women with intramural fibroids. Now, if someone has intramural fibroid, we're not talking about submucous fibroids, but again, that study which I showed you from Oxford Journal, Human Reproduction Journal, does clearly show that subserous fibroids also may cause infertility, although lesser impact than submucous fibroids, but they do have a role to play in infertility. And laparoscopic approach is associated with significantly higher success outcomes compared to laparotomy. I don't think there's any debate about it. Comprehensive and personalized approach after discussing the pros and cons of myomectomy with the patient. And it is often difficult to accurately advise each individual patient about what eventually at the end of the counseling the patient would want is, they want you to say 100% pregnancy will happen, you undergo the surgery. Now that is what they want to hear, but we know that we cannot commit it. We cannot say. All we can say is the pregnancy chances will significantly improve following a removal of the fibroid, but we cannot guarantee. But all they want to hear is she will get pregnant. Thank you. And now we invite any questions if you have, please.
So yeah, thank you, sir. That was a very elaborate presentation on fibroid, and there are a lot of questions, sir. So we are ready to take the questions.
Yeah, please.
So there's a question called torch. If in torch panel, if CMV IgG positive, is it necessary to treat? I think IgG positive means it's a later infection and it's not at all an active infection. There is no role in treatment of IgG positive cases. We can just proceed them as a normal case instead of treating them. Dose and monitoring of heparin, please elaborate. So heparin, generally what we use is 40 international units subcutaneously every day. And for monitoring, LFT and RFT and CBC would do. And there's another question called parenteral or oral progesterone and preferred. Some literature say that oral progesterone can be litholytic. Yeah, definitely oral progesterone. There are literature which says it might be litholytic if it is used for a longer time. Let's say if it's used till delivery or more than 28 weeks, but up to 28 weeks, it plays a safer role. And generally, what we do is we stop around 12 weeks of gestation and then taper it down till 28 weeks in case of recurrent pregnancy loss, and then still taper it down to make it 0 after 28 weeks. Are there any adverse effects with intralipids? Not really, but when you're starting on intralipids, it's very important that the patient should not have any allergies to groundnut, egg, and soya. Make sure that they don't have allergies to this, and then the intralipids should always be given in a setup of MICU where everything is available, like your oxygen, your the BP apparatus, your ventilator support, and an anesthetist should be available when your intralipids is on flow. ABO incompatibility, yes, there is a lot of ABO incompatibility which causes recurrent pregnancy loss prior, but I think nowadays we are very well versed with ABO incompatibility, and we are giving off this antibodies, I mean anti-D vaccine, so that we don't actually jump into this ABO incompatibility nowadays. Prior it was definitely there for RPLs. That's why I have not touched into ABO incompatibility. A patient with recurrent pregnancy loss came to OPD with TSH of 4.8. With the day 2 of cycle, should we have to start with her with a drug? Yes, definitely TSH 4.8 in case if she's going in for fertility treatments. you have to start off with a minimal dose of 12.5 and monitor her by doing a repeat TSH after 6 weeks, that whether dose is accurate for her or not. Where to use dexamethasone in RPL? I have clearly mentioned that there is no role of dexamethasone in RPL once she is pregnant, but then if you have an RPL case, probably you can use dexamethasone 0.25 mg if you're doing a fertility case. Let's say if you're inducing an ovulation induction or you're trying for a super ovulation, then this dexamethasone helps in getting a good follicle. That means it improves the folliculogenesis. So you generally start off with from day 2 to day 20. That's what we suggest, till day 20, and then stop it off. Ma'am, sudden stoppage of dydrogesterone, will it cause any withdrawal bleeding? Not really, but I would then generally ask the patients to taper instead of bluntly stopping the medication. There is another question called PCOS patient on metformin complains of GI side effects. Is there any drug of choice? There is definitely no alternative for metformin. Probably you can give them a break of 1 or 2 days, or start off with a minimal dose of 500 OD and then slowly increase your dose to 1.5 grams a day. That would be opt. And I think you should prior say them that, okay, this drug is definitely going to cause some side effects like GI effects, so that at least the patient knows what is going to happen. Metformin and prolactin doses: metformin 500 mg OD for 1 week and then increase to BD, and then if at all it is a very resistant PCOS, you can actually make it TID. For prolactin, don't jump off with giving a prolactin treatment with cabogoline right away without having 2 reports in 2 different labs with a rise of prolactin. In case of that's the case, cabogoline 0.25 mg twice a day for 5 to 6 days should be good enough when your MRI is normal. If in case your prolactin levels are too high, then please go ahead to see your MRI. Methods to reduce sir. I think the next questions are yours, sir.
Yeah, the method to reduce intraoperative bleeding and adhesions later. There are only 2 or 3 methods to reduce bleeding. One, the wonderful drug is vasopressin. It takes 20 units in 200 ml of normal saline is what we take, and that you inject in the capsule before giving the incision on the myoma. The second is even that larger fibroid, which I showed, almost 32 week size fibroid, we could do with vasopressin, and we did not do uterine artery ligation. The other technique is doing internal iliac ligation and then removing it at the end of the surgery. If you can't remove it, you may leave it. It will still not cause any problem. There are many surgeons doing that way also. But every time I've gone and used only vasopressin, and we never had any problem. Then the surgical question, I'll just finish off. In case of large fibroid, and we don't, and there is also question about adhesions later. Now, adhesions, there have been many things which have been tried: Sepra film, then icodextrin 4%, which is adept. Then there is regenerative cellulose, which is Interseed. When you look at the Cochrane evidence database, it does not suggest anything which works against adhesions. The only thing which has shown some promise is Interseed. Interseed is the mesh which I am showing you in all the surgeries. That is something which has been shown to be effective in reducing adhesions, although not very effectively, but amongst the available adhesive lytic agents, that is the best one. Then in case of large fibroid and we don't have a morcellator, how to remove it? Now, if you have done a myomectomy, you don't have a morcellator, I don't know what you mean by large fibroid. If it's something like a 4-5 centimeter fibroid, you might as well remove it from the posterior fornix. That's the best way. So you still don't have big scars on the abdomen. Otherwise, the other way is to give a suprapubic incision, which can be a small mini laparotomy kind of incision, and from there you can still take out big fibroids by doing coring technique. So grab the fibroid, even if it is a 10 centimeter fibroid, give say 4-5 centimeter incision suprapubically, pull it out with your nice tooth valcellum or single tooth tenaculum or bulldog clamp, whatever you have, and then core it like you would do vaginal morcellation of fibroid or a large uterus. In similar way, do it from the incision, suprapubic incision, and core it and take the fibroid piecemeal. So that is how you would do if you don't have a morcellator. Then I think that is done for me. No, sorry. In case of large fibroid, yeah, that's done. How to remove? Yeah, take over, Pallavi.
Yeah, thank you, sir. So they wanted me to tell the dose of dexamethasone again. It is from day 2 of stimulation to day 20 of stimulation, which is 0.25 mg OD dose, and then stop after day 20. That's a dexamethasone only during the ovulation induction. and role of oral and injectable progesterone after 28 weeks of pregnancy in RPL. Generally, I don't think so there is any role, but yes, we had a patient wherein she had multiple recurrent pregnancy losses, like she had 9 losses. In that patient, I had to put her till 37 weeks, till we were about to deliver her by by an elective surgery. That was like few cases, like 2 or 3 cases which we have done that way, and she went ahead with a good baby. That's just a few cases wherein we have prolonged after 28 weeks as well. All PCOS cases, should we put them on metformin, or if it is only with high OGTT levels, I would definitely recommend, even if your OGTT levels are normal, metformin would do a great job in PCOS, because in PCOS the main thing is hyperinsulinemia. So metformin is going to cut down on your hyperinsulinemia and give you a good quality egg. So that's the thing. During induction or to be started after conception. I'm sorry, I didn't get this question. Low molecular heparin, how long should we give?
Meaning, is it during ovulation induction or should start after conception?
Which metformin, sir?
Yeah, during induction of
Metformin.
ovulation.
Yes.
Induction
Generally,
means
what they
ovulation
say
induction.
is, yeah, yes. Basically, metformin, what they say is, even prior to you start off with ovulation induction, if you give 2 to 3 months prior, it has a good impact before you start off with ovulation induction. So that's what you have to start off, not after conception. So low molecular weight heparin, how long should it be given? We generally give it in IVF cases till 12 weeks of gestation, and then depending on the case, if it's a recurrent pregnancy loss, we had continued it till 28 weeks in very few cases, but generally we stop it at around 12 weeks after tapering the dose, not an absolute stop.
Sorry, you're talking
Role
about
of
what, Pallavi? You're talking about
heparin,
metformin.
sir.
Heparin you
Heparin.
stop at 12 weeks.
Yes. In case of IVF cases.
Oh, IVF, because we normally would continue it.
Yes, in
Because
case only it is an IVF, clean cut IVF case, we stop it at 12 weeks. If it's just one miscarriage or one implantation failure. But if it's a recurrent miscarriage, we had continued it almost till 36 weeks in few cases.
Yeah.
Role of myoinositol as insulin sensitizer, yes, it does a good job. In case of polycystic ovaries, you can start off even before you do an ovulation induction. In case of recurrent IUD at 7th month, so we really need to dig into the case of what is the reason at 7th month having an IUD.
No, recurrent IUD in 7th month. This is out of this infertility thing. I think what
Right.
they're saying is this is something to do with maybe diabetes or fetal growth restriction or those
PIH.
kind of things. It's not when you are having recurrent intrauterine death at 7th month. It is very odd to see recurrent there. If you're talking about extreme preterm births, then it can be cervical incompetence that or PPROM. They may have some
High blood pressure.
general infections which may be leading to PPROM and but pure IUD. If you're talking about stillbirth and no rupture membranes, no choriamnitis, nothing, then you're probably looking at factors like fetal growth restriction or diabetes, and also look at maternal age and other medical morbidities like preeclampsia or chronic hypertension, those kind of things. Yeah. And the other thing is, I see here, sir, can you tell the dose and dilution of vasopressin? Vasopressin is given 20 units in 200 ml of normal saline. That's the standard we use, and you don't have to use all of it in one go. You can use it if you have 3 or 4 fibroids at different location. Use it for first fibroid, renucleate it, or however you do it. So you don't have to give it all in one go. You can still change it based on the location of fibroids. Yes, in case of recurrent IUD at 7 months, we've done that. Recurrent IUD at 7th month and APLA positive. APLA positive, all right. In that case, I give it till 34, 36 weeks and keep a low threshold to deliver once she reaches 36 weeks. And if you are someone who had recurrent IUD at 7th month, I wouldn't feel comfortable continuing till term. Once I get that, it depends upon again in which kind of setup you are in. But 36 weeks, 37 weeks, I'll have low threshold to deliver that baby. So and stop low molecular weight before that, around 36, 35, 34 weeks. Agree, Pallavi?
Yes, sir. Right, sir.
I think there are no more questions, so we can log off, shall we?
Yes, sir.
Yeah, okay. So thank you all for attending, taking time out and attending this at late in the evening. And it was nice to do this. Pallavi, thank you also. for the nice presentation.
Thank you, sir. Yeah, thank you,
Okay.
sir.
Thanks. Bye.